Thank you all again for being with us. And we have about 50 participants right now on the call. This is great. So the next presenter is Dr. Roland Krug. He's Associate Professor in the Radiology Department. He is also the Director of the Pathophysiology Core in our REACH study here. He is mostly doing research on novel MRI methods and spectroscopy as tools for musculoskeletal conditions and pain. So I'm very looking forward to his talk. So Roland, take it up.
Yeah, thanks very much, Wolf, for the kind introduction. So can you see my slides fine?
Yes.
Okay, perfect. So today I'm going to talk about muscle MRI methods and applications. And I'm going to start out to introduce you to some of the muscle MR spectrums we can obtain. And then the next topic is one of my big focus in my lab, that's muscle fat quantification. So I'm going to spend quite a bit of time on that, and also the applications and clinical applications. We investigated here. Whole body composition is a topic in my group. And then also I think what would be of interest for this audience is muscle perfusion contrast enhancement in MR-guided focused ultrasound treatment. So this is a small preclinical study we did to look at treatment of the facet joint and SI joint, and then treatment results in muscle perfusion. And so another topic is T2 mapping and muscle MR elastography. So the MRI and imaging and spectroscopy for muscle is a pretty wide field. So I'm not going to cover everything. So for example, diffusion MRI is not going to be a part of my talk. So it's going to be mostly what we do at UCSF, or also what we want to do in the future. Okay, I want to first start out to show you some of the MR spectra we can obtain in the muscle. So you can see here on the top, the first one, that's a proton spectrum. And you can see here different peaks we can obtain. And so I want to draw your attention in particular here to the fat peaks. So there's a intramyocellular lipids, IMCL peak, and the extramyocellular lipids, EMCL peak. And I'm going to talk a little bit more about these two peaks in the following slides. And then there are some other peaks, and of course the water here is suppressed, and it's usually 3.2 ppm to the left of the fat peaks. So by special equipment and tuning our coils to other nuclei frequencies, we can also obtain a carbon-13 spectrum here with several peaks, as well as a phosphorus 31 spectrum. So there's quite a bit of possibilities using a spectroscopy. So what I want to do here is I want to show you a little bit. I want to explain the terminology we use for the different muscle compartments using a bovine meat here. So you see here the subcutaneous fat, of course, nicely depicted. And then the intramuscular fat, so that's the fat here in between the muscle compartments. And then there is the intramuscular fat. So this is the fat within the muscle. The intramyocellular lipids, what we previously saw, the peak in the spectrum, these are fats stored in droplets in muscle cells. And these are the red dots shown here. And IMCL is a very metabolically very active component. So I want to give you some examples here for IMCL, why this is so important. So this is an individuum before and after exercise. So pre-exercise, so you see here the full proton spectrum. And then post-exercise, you can see here a greatly diminished IMCL peak. And when you look at the difference, you see it's the pure IMCL peak. So that also shows you that the MCL is a metabolically very active pool that can be recruited by the skeletal muscle during exercise. There's also some other research looking at increased IMCL in insulin-resistant subjects compared to EMCL. So you can see here on there's a publication from Bush et al. On the left, you see an insulin-sensitive subject. There is very little IMCL, and then there's the insulin-resistant subject, and you see the IMCL peak is greatly elevated here. And of course, in addition to insulin sensitivity, IMCL levels are also dependent on many other factors like gender, obesity, diet, exercise, and so on. So that just I just wanted to give you some overview in terms of spectrum, what you can see and how important some of these peaks are. But let's switch to MR imaging, and that's what we do mostly in my lab, and that's also part of REACH and the backpack efforts, what we do here at UCSF. So you see here a typical T1 weighted fast spin echo sequence, and you can clearly see the fatty infiltration as a bright signal and the muscle as a dark background. So it's fairly easy to distinguish here the two compartments, the fat compartment and the muscle compartment. And this is very typical for most fast spin echo sequences. So if you go the fast spin echo sequences or turbo echo sequences, spin echo sequences, they are the workhorse of the clinic today. And they are done a lot. So T1 weighted and T2 weighted fast spin echo sequences are widely available. And both T1 and T2 depict the muscle relatively dark. And that's because muscle has very short T2 T2 properties and very long T1 recovery times. And that means that the muscle is always relatively dark in T2 and T1 weighted images. The reason why we pick T1 weighted images to look at the muscle is because most of the time the T2 weighted sequences are fat suppressed, because the clinicians, they want to see other things than muscles. So they want to see fluid and things like edema and other things. So that's why T2 weighted fast spin echo sequences are mostly fat suppressed. So we cannot see the fat, and they are not of great use for us. So the T1 weighted images are usually used for qualitative fat assessment. And then, as I said, the muscle is always relatively dark in these fast spin echo sequences, and the fat is always relatively bright. And that has to do with some diffusion effects and some J-coupling effects. But in fast spin echo sequences, muscle fat turns out to be very, very prominent unless you suppress it, of course. So here's some work from Jeannie Bailey, who is very interested to look into muscle fat and muscle fat quantification. So here in this study, she investigated some methods, how we can use these clinical images, the T1 weighted and T2 weighted images, and make some assessment about the fat. So what you need to do, of course, is you need to establish some sort of threshold so that you can distinguish the fat compartments from the muscle compartments. So Jeannie here looked at different methods to do that, and then you get basically a binarized image where you can nicely see all the voxel that you attribute to fat and the voxels that you can attribute to lean muscle tissue. So the application Jeannie found for this was prolonged unloading during space flight. So you can see here again in these images, there's an individual before a space flight. And after thresholding, you can see there's moderate amounts of fat in the muscle. And after post flight assessment, you see here there's much more fat infiltration in the muscle. So Genie also concluded here that changes in multifidus lean muscle composition is associated with changes in spinal alignment. So you can see that here on the right side, the graph here on the top, association with spinal alignment, and here the bottom graph here shows you the association between lean muscle composition and range of motion. So Genie concluded in this study that multifidus muscle composition is a risk factor for post-flight chronic low back pain and disc injury. So in this study, Genie used the thresholding technique, and that's very easy to do, and clinical images are widely available. But can we do a better job in being more quantitative with the fat assessment? Yes, we can. So there are Dixon-based methods in MRI, and these methods, they are basically sampling the water and fat spectrum. And what you do, you have different sampling points to assess all the peaks. And as you remember from my first slides, each peak has a different frequency. So you have to sample all the different frequencies and capture all the peaks. And then you get here these proton density fat fraction maps. And what these fat fraction map, they tell you, in each voxel, you have a very accurate percentage of fat. So you can see here in this subject, the red is the subcontinuous fat. So this is really high fat content. So you have in most of the voxels pretty close to 100% fat. And then you look here at some of the spinal muscles, and you see here very low fat content and then some of medium fat content. But each voxel gives you the fat content in percentage in that voxel. And this method is very reproducible and very accurate. So you can actually calculate the fat in milligram from this proton density fat fraction map. So it's a very quantitative measurement for fat assessment in the muscle. And then, of course, Genie was also very interested to use some of these more advanced Dixon techniques for her studies. So you can see here again, this is a fat fraction map. What you have to do, you have to outline the individual muscles and segment individual muscles, and then you can commonly you can build like an average fat content in these muscles by just summarizing the fat content in the different voxels in the region of interest. Of course, the pros here is the accuracy of the method, and there's less post-processing because you already have a fat fraction map and you just need to identify your region of interest. The cons is somehow a little bit availability on the scanner of the more advanced techniques. So then in terms of chronic low back pain, so we have a great data set from one of Jeff, our ones, which just ended a year or two ago. So we have a great data set with subjects with low back pain, and we have also these Dixon images and other advanced images. And so Genie, she used that database and she looked at some of these Dixon images. And what she found is that paraspinal muscle quality does not show consistent significant differences between patients with chronic low back pain and controls. However, so once she started to pool the group with the patient group with low back pain into two groups, one group with low ODI and one group with high ODI. So ODI is a patient-reported disability index. So she found differences here. So you can see the blue line here are the controls. So the controls are the same in both groups. The red line here is patients with low ODI, and here patients with high ODI. And you see here across all lumbar spine levels that the patients with high ODI had significantly increased mean fat fraction, as you can see on the y-axis. So then Aaron Fields and we are very interested also to look at end plate damage and how does that relate to muscle quality. So on the left side, you can see here a subject again with chronic low back pain and also with end plate damage. So you can see here clearly that there's quite a bit of fatty infiltration in the spinal muscles. The more like orange and green areas. Whereas looking here at the patient with chronic low back pain who did not have end plate damage, there was very little fatty infiltration in the muscle. So then Aaron also, and we went a step further and looked here at the prevalence of end plate damage in these patient population from Jeff's grant. And there is a, there was a high prevalence in L4, L5 in the patients who had damages in the end plate. And what Aaron now did next, so L4, L5 had high prevalence of end plate damage. So then Aaron went ahead and he pooled the data again in two groups. So there was one group of the patients who had good muscle quality. So that means very little fat. And then there was another group who had poor muscle quality. So that means they had a lot of fat in the muscles. And so Aaron found here that the odds ratio was very high in the group with poor muscle quality. So that means that SEP damage at L4, L5 was predictive of chronic low back pain in patients with higher fat values, so poor muscle quality, but not in patients with lower paraspinal fat values. And this was here done in the erector spinae, but also similar results were obtained in the multifidus. Here you can see again that subjects with poor muscle quality had an extremely high odds ratio, and subjects with good muscle quality had a lower odds ratio. So I just wanted to show here a brief image for what we can do as well. We can do whole body composition. You see here a water image of the whole body and a fat image of a whole body, and then you can also acquire fat maps. So we can look here at, for example, thigh muscle volume and thigh muscle fat, as well as other fats, visceral fat, subcutaneous fat, and so on. So that's also good, and of course, spinal muscles. So that's also good means to look at a whole body in relatively short scan time. So now I want to switch gears a little bit and go to contrast enhancement. So I've been very interested to use some new techniques called MR-guided focus ultrasound, which can potentially be used to treat back pain. And so here's an example of facet joints. So what's usually done for facet joint pain, the nerves are ablated with an RF needle. And this is a rather invasive technique. So using MR-guided focused ultrasound, what you can do here is, so you have this is basically the MR table, and it has a ultrasound transducer within the table. So you can use this transducer to apply this focused ultrasound ablation to here's the fibroid, but to any other target. And for us, in this study, so that was a preclinical study, we were very interested in the facet joint and in the SI joint. So we looked here at a swine model. So you see the animal here is lying on the MR table. There's some gel padding here, and then there's a focused ultrasound transducer and targeting here the facet joint. And then with MR, you can also monitor the temperature during the sonication, and you can look at some variations of the sonication energies and sonication frequencies. And then in order to evaluate this treatment, we had to look here at the muscles. So what happened in the muscles? And you see on the right side, the T1 and the LAVA, these are basically T1 weighted images after contrast enhancement. So there was contrast injected, and then you wait a couple of minutes, and then you acquire some MR images. And you can see here, always there's this, in the region of the ablation, there's this dark spot in the middle, as you can see here. And there's always this bright ring in these contrast enhanced images. And the reason for that is that in the targeted area, so the ablated area, there's necrosis. So the contrast agent cannot penetrate into that area. And that's why it shows up as a dark spot in MRI. And then because it cannot penetrate into this area, the contrast accumulates outside. That's why you see here this bright ring. And then we did also pre-contrast imaging, T2 weighted, so you can see here also very strong fluid and edema. And that the size of these lesions also varies a lot with the applied energies. So again, here you can see also in the axial images nicely the necrosis and the ring of the contrast agent in the muscles here. And then you see here huge edemas in the muscle as well, close to the ablated region. So we also did, in addition to facet joints, we did also the sacroiliac joint in a similar swine model. And we targeted the lateral aspect of posterior sacral foramina and ablated the lateral branches of the S1 to S3 nerve roots that infiltrate the SI joint. So you can see here on this picture the nerve roots coming out of the foramina, and that's where we target our ablation around the foramina here to hit the nerves. And this is, you can see here this in the oblique coronal MR orientation. You can also see here the foramina, and that's what we use for the planning of the treatment. So again here, you can see in MR, you can calculate a thermal dose overlay. So you see where was the ablated region near the foramina. And then here you can again see how the transducer basically hits the target. And so again, how does delayed contrast enhancement looks in the muscle? So on the right side, you can see here that again, it's the same effect. You see a dark spot in the middle, so there's not much penetration of a contrast agent because of necrosis. And then you can see here this white ring outside where the contrast agent accumulates. And then also you can see here again on the T2 weighted pre-contrast images, a lot of fluid and edema going on. Okay, so now I want to switch gears again and look at some work that colleagues in Munich have done for myofascial pain syndrome. And we just heard a very exciting talk from Jay about the trigger points. So there's a lot of interest. And so Nico Solman, who works currently in Munich, he was very interested in looking at MR techniques to define some of these trigger points, because as you know, palpation is not very accurate. And Nico is also, so he published that last year, and He actually was scheduled to join my lab earlier this year, but so due to Corona, we had to postpone that. So hopefully he can join us here at UCSF very soon next year and help us to establish some of these methods also at UCSF. So what Nico did in this study, he applied T2 mapping of myofascial trigger points in 10 subjects with clinically confirmed migraine. And in the study, he found 15 out of the 16 trigger points, according to physical examination, were detected in the color-coded T2 maps. So T2 mapping might provide a more objective quantitative assessment of trigger points. So you see here again, the group here in Munich, they acquired some Dixon type images first to look also at fatty infiltration, and then they did a T2 map, and you can see here the muscles and the regions of interest here of the muscle, and this small enhanced signal region in the middle, and that's identified as a trigger point. So the difference in signal or in T2 was significant between the trigger points and the muscle here, both on the right side and on the left side. And again, this was just published last year. So another method we are kind of exploring at the moment to get also some quantitative measure of stiffness is magnetic resonance elastography. And there's not too much work actually that has been done in the muscles, but there's a lot of work like in the liver, for example. But what you do here to use MR elastography, you need a sound wave transducer. So there's a sound wave driver which you need to attach to your region of interest. So in this case, it would be your back muscles, your spinal muscles here, and then you strap it, and then the subject would lie on the MR table, and then you can apply sound waves during the scan. So how does that look? So this mechanical driver transduces these sound waves, and then you can, in MR, you can acquire images which are what we call phase, we call this phase images, where we can get actually a pretty good assessment of the wave that's moving through the tissue. And from these images, you can go a step further, and you can calculate the shear stiffness in kilopascal. So that's called an elastogram. So there's one study that looked at using MR elastography here in the back. So you see here the back muscles, multifidus, and the other compartments here. And so they applied the sound waves in that regions, and then they obtained these wave images here on the right side. And then they calculated these shear modulus maps. So you see the map here on the left side. That's kind of a map while the subject was in the scanner but was at rest. Whereas the next image here in the middle was acquired when the subject was stretching the back muscles. And then very striking is here the image on the right. So that was acquired while the back muscles were, the subject was contracting the back muscles. So you can see here, clearly here a change in the stiffness, which can be assessed by these methods.
You have to conclude soon.
Yes, so that concludes my talk, and I just wanted to acknowledge our team for REACH. So this is Jeff, who is leading the entire endeavor. Thomas Link, I work very closely, who's our chief MSK radiologist. And then Jeannie and Aaron, they are both very, very interested in using these imaging methods for their research. And then I have two research associates in my lab, Jamin Zhu and Ravi Chashad, who are extremely motivated and interested to help us applying some of these MR methods to tackle the problem of back pain. So thank you very much for your attention, and I'm looking forward to the questions.
So you're all invited to bring some questions. As long as there isn't anyone yet, and I can ask my question. So the ultrasound technique for eliminating, or for instead of the RFA for the facet joint, is that painful? Does it happen in anesthesia, or how does it work? I mean, I only know that from kidney stones as a technique.
Yes, so that's an excellent question. So the reason also we did that in the facet joint and in this and in the SI joint in the preclinical model, in the swine model, is there is currently no FDA clearance for that technique, but there's groups in especially in Germany who have done patients with facet joint pain, and they use MR-guided focused ultrasound to ablate the nerves in the facet joint, and they have very, very good results. It's non-invasive because you don't use a needle for the ablation, but it's also time intensive because you need to get the subject on the table. Yeah, there's of course there's some sedation, but in the group in Germany does that on a regular basis. They do that every week, and they have very good outcomes.
So they gotta be sedated.
Yeah.
I can ask one more question. At the beginning, you brought in this spectroscopy examinations. I was wondering how fine-grained the resolution of this can be, and if that can possibly pick up inflammatory markers.
You mean the resolution of the peaks?
Yeah, so the area that you assess, you know, I understood that you have a little window there, an area of interest that you analyze. How small can that be? I mean, can you go into, like, find a trigger point, for example, and find out whether they have different inflammatory markers on spectroscopy? Is that theoretically, or maybe it's not that fine-grained? That was my question. Yeah,
so spectroscopy, it's a very sensitive technique. So you need really strong magnetic homogeneity. So your magnet needs to be shimmed very well, but then you get very clear peaks in terms of, you know, what peaks you potentially could see to identify trigger points. I don't know. I don't think anybody has looked at that. But it's a good point. But for the muscle, it should be you get relatively clear peaks because you don't have that many confounding factors. We do some spectroscopy in bone marrow. Then you have the spectra broadens because of some magnetic influence from the bone, because the bone is more diamagnetic. But for the muscle, I think you should get a fairly sharp spectrum.